Hello, and welcome to Group 4 presentation. We will discuss mental health in the African American youth community, a public health topic for children and youth behavioral initiative in California. Slide 2, please. Before we get started, we would like our audience to be aware that we will discuss suicide, a sensitive topic that may be distressing for some listeners and viewers. African American youth in California face elevated risk of suicide. Data shows that in 2019, an estimated 12.6% of 9th through 11th grade youth reported experiencing suicidal ideation. In 2021, about 30.15% of emergency department visits were for self-harm based on rates for 100,000 youth. The graph to the right demonstrates a little under 200 emergency department visits in 2019, with a slight decline in 2020, and then an increase in 2021, which is above the 2019 rate. Next slide, please. Between 2016 and 2021, the rate for African American youth suicide increased by 33%. Suicide has become one of the leading causes of death for African American youth between the ages of 10 and 24, which is disproportionately higher than the average rate in California. The trends show on the left a depiction of an increase of 6 out of 100,000 youth who committed suicide to a little over 9 out of 100,000 by 2021. These rates were even higher, reaching nearly 10 out of every 100,000 youth in 2020 during COVID-19. Next slide, please. These numbers are alarming and represent lives being affected at an unacceptable level. This is a clear indication that systemic issues must be addressed with urgency and action, including effective tools for targeted intervention and policies that address the root causes. We want to urge policymakers into action through policy shifts to help mitigate the risk factors to ensure that African American youth are receiving the mental care that they need to thrive. Next slide, please. In this slide, we present information about some of the contributing factors that lead to suicidal ideation and suicide in the African American youth community. This community faces trauma in the form of community violence, familial stress, over-policing, and in the criminal justice system. Systemic racism, socioeconomic conditions increase these risks. Stigma due to historical injustices, systemic inequities, both connected to racism, divestments, negative pathologies, and a lack of resources and quality care. Cultural mistrust of the healthcare system, again due to historical injustices and systemic inequities. An underrepresentation of African American mental health providers with lived experience to connect to youth for culturally concordant care, and barriers this group faces in accessing culturally responsive mental care. The image to the right explains the process through which cumulative racism contributes to the development of post-traumatic stress disorder, or what some scholars call continued traumatic stress. The model incorporates elements such as epigenetic risk factors, ongoing experience of racism, and institutional barriers to treatment, illustrating how these factors compound and contribute to mental health challenges for impacted individuals. This leads to symptoms like hypervigilance and mood changes, which maintains or exacerbate PTSD or CTS symptoms. Next slide, please.
Thanks, Crystal. And so our problem statement identifies that African American Black youth in California experience suicide rates higher than the state average. This disparity highlights the need for targeted mental health interventions that address unique challenges faced by this community. And so our policy alternatives are focused at reducing these disparities and improving mental health outcomes. Next slide. So to address this problem, our group considered 4 policy alternatives: maintaining the status quo, school-based mental health, suicide risk screening, and mental health education. Each alternative offers a unique approach to addressing the mental health crisis among African American youth. Next slide. For the first alternative, the status quo, is to continue with the California Mental Health Services Act, which funds mental health services statewide. While the Mental Health Services Act has made strides in prevention and early intervention, it lacks sufficient focus on culturally competent care for marginalized communities. Unfortunately, this means African American Black youth still experience disproportionately high suicide rates, showing the need for more targeted solutions. Next slide. For policy alternative number 2, we propose embedding mental health support in schools, which can remove barriers to care by integrating services in a trusted environment. Programs like peer support groups and student-led initiatives foster resilience and create safe spaces for students. Normalizing mental health care in schools also reduces stigma, making it easier for African American youth to seek help when they need it. Next slide. For policy alternative number 3, we propose expanding the use of suicide risk screening tools during annual physicals and emergency department visits to ensure consistent opportunities for early detection. To be effective, providers must be trained to administer screenings in a culturally sensitive way that acknowledges the unique stressors faced by African American youth. Pairing these screenings with immediate referrals to culturally appropriate mental health services ensures timely support. Next slide. Our last policy alternative, number 4, we propose expanding mental health education. By including it in health or social studies classes, we can foster understanding, reduce stigma, and promote health-seeking behaviors among youth. Additionally, partnering with local organizations, churches, and community leaders allows us to meet the community where they are, ensuring programs are culturally relevant. Offering workshops for parents and caregivers further empowers families to recognize early warning signs and seek help. And now I will turn it over to Melanie.
Thanks, Adrian. We have elected the following 4 evaluation criteria: access, political resilience, cost effectiveness, and impact. We have defined access as the number of African American youth that receive the intervention. We have defined political resilience as the policy's position to gain bipartisan support. We aim to measure this by observing the support of the policy alternative in public opinion polls and statements of action by influential policymakers, advocacy groups, and coalitions. We also consider current policies being implemented or on their way to implementation that complement the values and outcomes of the policy alternative. We defined cost effectiveness as the cost of the program to be implemented, and then it be reasonable within budget constraints relative to the impact it has on the targeted community, as well as the potential long-term cost savings. Lastly, we define impact in several ways, including, and most importantly, declining suicide rates relative to previous years, increased knowledge of resources, such as prevalence of educational campaigns, and enhanced pathways to access care, such as increased coordination between community and medical services. When comparing alternatives, we first had to designate weights to our evaluation criteria. We prioritized impact with the highest weight, while acknowledging that there cannot be significant impact without access. This weight scale reflects our team's values and the urgency toward promoting African American youth's mental health. Now let's look at the rankings. Status quo is ranked lowest as it fails to meet our evaluation criteria, with the exception of being ranked medium for political resilience, considering that it has been accepted into policy and implemented today. While we have covered this sufficiently in our background, the status quo fails to effectively reach and support African American youth with mental health treatment and prevention. Meanwhile, we have ranked school-based mental health support the highest, as this intervention addresses access by meeting youth where they commonly are at school, as well as normalizing mental health and providing services for African American youth to lean on when they need support. When determining cost effectiveness, we scored this as high as we considered the long-term cost savings in this preventative healthcare intervention, reducing downstream costs such as mental health-induced hospitalization. Next, expanding suicide screening rates is second highest, with relatively high access and impact ratings. While universal screenings are capable of providing access to the highest number of individuals, that high touch point comes with a cost, justifying our low cost effectiveness score, and as a standalone intervention doesn't have the same cost savings as a school-based mental health support. Despite its high cost, we've ranked it medium for political resilience, given Gavin Newsom's signing legislation in 2022 requiring suicide screenings for youth at acute care hospitals. Lastly, mental health services rank second to last, but still scored notably higher than the status quo. It's important to mention our low ranking of access, since while mental health education programs will lower stigma, the existing stigma pre-intervention may prevent communities from opting into the program. To conclude with high-level trends, we see status quo ranks significantly below average and school-based mental health support significantly above average. These rankings reflect our group values to not accept the outcomes of the status quo and instead look toward policy alternatives that intervene at the community level and provide the tools to treat mental health issues. Now I'll pass it to Jordan to go into detail regarding projecting outcomes.
Thank you, Melanie. To evaluate the potential impacts of our policy options, we analyzed outcomes across benefits and risks for each alternative. First, maintaining the status quo means continuing to rely on the Mental Health Services Act, or the MHSA, which provides services to some youth, but it falls short of addressing the racial disparities in suicide that disproportionately affect African American and Black youth. While recent updates to MHSA aim to allocate 51% of funds to interventions for individuals under 25, the funding source, a 1% tax on incomes over 1 million, introduces uncertainty due to fluctuations in state revenue. Next, embedding mental health supports in schools stands out for its potential to increase access to services statewide. By addressing mental health in familiar and accessible settings, this approach could significantly reduce risks through early intervention. However, implementation challenges such as securing funding, addressing workforce shortages, and combating stigma remain key risks. Next, expanding the use of suicide risk screening tools offers a targeted approach by identifying at-risk youth during routine healthcare visits. While this intervention enhances early detection and referral to mental health care, its success depends heavily on sufficient training and provider availability. Quality implementation may also require incentives or additional funding. Lastly, implementing mental health education programs has the potential to increase awareness and reduce stigma. By empowering communities to recognize mental health challenges, this option could foster early intervention. However, its long-term success relies on community buy-in and sustained political and financial support. These projections highlight both the promise and the limitations of each approach, helping us to prioritize strategies that balance access, political feasibility, cost-effectiveness, and meaningful impact. Next slide, please. Our policy recommendation is to embed mental health supports in schools. This approach leverages the existing educational infrastructure, making it feasible to integrate services where youth already spend a significant portion of their day. Additionally, the political feasibility of this option increases its potential for consistent and durable effects over time, as it aligns with the growing public awareness of the mental health crisis affecting African American and Black youth. However, implementation presents challenges, particularly the administrative complexity of allocating resources equitably to schools with varying needs. Moreover, this policy may not reach all students, including those who are homeschooled or attend private schools, which represents a significant limitation in its potential impact. Our analysis also recognizes funding as a critical consideration. The success of this policy depends on navigating federal funding uncertainties, political support, and state revenue constraints. Future research should investigate cost-effective implementation strategies, equity impacts across different school settings, and mechanisms to extend support to students outside of traditional public school systems. Next slide.
In addition to policymakers, our group wants to encourage listeners and viewers to take action. If you or someone you know in California is contemplating suicide or can benefit from support, please reach out to the below resources. Next slide, please. Thank you for watching our presentation.